Welcome. Today, we're diving into necrotizing ulcerative periodontitis, or NUP, a severe gum disease that extends beyond the surface, affecting deeper periodontal structures. NUP is a progression from necrotizing ulcerative gingivitis, leading to loss of attachment and even bone loss. Understanding NUP is crucial for both dental professionals and anyone interested in oral health, as it can have significant impacts on quality of life. In this video, we'll break down the types of NUP, their clinical features, and how they're treated. Let's start by understanding what sets NUP apart from other periodontal diseases. Necrotizing ulcerative periodontitis can be classified into two main types based on its relationship with acquired immunodeficiency syndrome, or AIDS. The first type is non-AIDS associated NUP, which typically arises after repeated attacks of necrotizing ulcerative gingivitis. The second type is AIDS-associated NUP, which occurs in individuals with compromised immune systems, particularly those with HIV. Both types share similar features, but AIDS-associated NUP often presents with more severe complications. Understanding these distinctions is key to proper diagnosis and management. Let's first look at the non-AIDS type of necrotizing ulcerative periodontitis. This form usually develops after repeated episodes of necrotizing ulcerative gingivitis. The clinical features mirror those of NUG, including painful necrosis of the gingival margin, which is covered by a grayish pseudomembranous slough. The affected margins are surrounded by redness, and patients may experience unilateral lymphadenopathy, fever, and malaise. Over time, the lesions can extend deeper, resulting in crater-like bone defects, especially between the teeth. Notably, deep conventional pockets are absent, as the necrotizing process destroys the marginal tissue entirely. AIDS-associated necrotizing ulcerative periodontitis shares many features with the non-AIDS type, but tends to be more aggressive. In HIV-positive patients, large areas of soft tissue necrosis are common, often exposing bone and leading to sequestration of bone fragments. These lesions can sometimes extend to the buccal vestibule or palate, evolving into necrotizing stomatitis. The compromised immune system in these patients makes the disease more severe and challenging to manage. To summarize, necrotizing ulcerative periodontitis results from the extension of ulcerative gingivitis into deeper periodontal structures, causing attachment and bone loss. It's classified into non-AIDS and AIDS-associated types. The non-AIDS type follows repeated NUG episodes, while the AIDS-associated type is more severe, with extensive tissue and bone destruction. Recognizing these differences is essential for accurate diagnosis and effective treatment planning. Treating necrotizing ulcerative periodontitis involves a combination of local and systemic approaches. The primary goal is to control infection, alleviate pain, and restore oral health. Treatment typically starts with local debridement of lesions, scaling, and root planing. Patients are instructed on maintaining excellent oral hygiene. Ultrasonic instrumentation with plenty of irrigation is often used to remove debris and bacteria. In addition, topical antimicrobials and systemic antibiotics may be prescribed, along with analgesics to manage pain. Now, let's shift focus to refractory periodontitis. According to the American Academy of Periodontology, refractory periodontitis refers to cases that do not respond to any treatment, regardless of how thorough or frequent it is. This is different from recurrent periodontitis, where the disease returns after remission due to inadequate plaque control. In refractory cases, the reasons for treatment failure are often unclear, making management more challenging. The causes of refractory periodontitis are varied. Risk factors include an abnormal host immune response, resistant strains of pathogenic bacteria, and failure to eliminate plaque-retentive factors like furcation involvement or irregular root surfaces. Smoking and systemic diseases can also contribute, leading to generalized lesions that don't respond well to treatment. Specific microorganisms such as Bacteroides forsythus, Fusobacterium nucleatum, and Campylobacter rectus have been identified in refractory cases. Research has identified several microbial complexes in refractory periodontitis. Haffagi and colleagues reported 3 major groups. One includes Bacteroides faucitus, Fusobacterium nucleatum, and Campylobacter rectus. Another features Staphylococcus intermedius, Porphyromonas gingivalis, and Peptostreptococcus micros. And a third involves S. intermedius and F. nucleatum. These bacteria are often resistant to conventional therapy, making eradication difficult. Clinically, refractory periodontitis is no longer considered a single disease entity due to the diversity of cases. Instead, the term refractory can be applied to any form of periodontitis that fails to respond to standard therapy. Patients may present with new areas of attachment loss or progressive loss in previously treated sites, often accompanied by persistent bleeding on probing. It's important to distinguish these cases from recurrent periodontitis, which is usually due to inadequate maintenance. Let's clarify the difference between recurrent and refractory periodontitis. Recurrent periodontitis refers to sites that are successfully treated but experience disease return, often due to inadequate maintenance. Refractory periodontitis, on the other hand, involves sites or patients that do not respond to conventional therapy, possibly due to infection with tissue-invasive microbes or immune incompetence. Antibiotic therapy is usually needed for refractory cases, while it's not typically required for recurrent cases. Managing refractory periodontitis requires a combination of antimicrobial therapy and mechanical debridement. Antibiotics are used to reinforce mechanical periodontal therapy and help the host defense system by targeting subgingival pathogens that persist after conventional treatment. In some cases, intrasulcular irrigation with povidone iodine or chlorhexidine solutions is effective. For localized lesions, local drug delivery systems in the form of gels, fibers, or chips can be used, offering smaller doses and minimal side effects. Several antibiotics are commonly used to treat refractory periodontitis. These include tetracycline, hydrochloride, amoxicillin, clindamycin, and combinations such as metronidazole with amoxicillin or doxycycline. The choice of antibiotic and dosage depends on the specific case and microbial profile. Subantimicrobial doses of doxycycline can help prevent periodontal destruction by controlling collagen and gelatinase production, while nonsteroidal anti-inflammatory drugs may reduce inflammation. Periodontitis can also be a manifestation of systemic diseases, especially those involving defects in neutrophil number or function. Severe periodontitis is often observed in patients with conditions like Papillon-Lefèvre syndrome, Chediak-Higashi syndrome, Down syndrome, hypophosphatasia, neutropenia, and Leukocyte Adhesion Deficiency. These systemic conditions compromise the body's ability to fight infection, leading to rapid and severe periodontal destruction. Papillon-Lefèvre syndrome is a rare inherited disorder characterized by early-onset periodontitis and hyperkeratosis of the palms and soles. Children with this syndrome often lose their primary teeth by age 3 to 6, and permanent teeth are lost soon after eruption. The syndrome is associated with defective neutrophil function, leading to severe periodontal destruction and early tooth loss. Chediak-Higashi syndrome is another rare hereditary disorder marked by recurrent bacterial infections, oral ulcerations, and rapidly destructive periodontitis. The syndrome involves defects in both neutrophils and monocytes, resulting in poor immune defense. Patients may also experience photophobia, respiratory tract infections, and neurological or gastrointestinal disturbances. Down syndrome, also known as trisomy 21, is a congenital condition characterized by mental deficiency and growth retardation. Oral findings include plaque, calculus, diastema, crowding, and high frenal attachment. Periodontitis in Down syndrome often features deep periodontal pockets, especially in the lower anterior region, with marked gingival recession. The increased severity is due to reduced resistance to infection and defects in immune cell function. Hypophosphatasia is a rare familial skeletal disease characterized by rickets, poor cranial formation, and premature loss of primary teeth, especially incisors. Patients have low serum alkaline phosphatase levels, and teeth are lost without significant gingival inflammation. There are juvenile and adult forms, with the adult form mainly affecting the incisor region. Reduced cementum formation is a hallmark of this condition. Neutropenia is a condition where the number of circulating neutrophils drops below 1,500 per microliter. This can be inherent or acquired, sometimes resulting from drugs or infections. Children with neutropenia often develop destructive, generalized periodontal lesions due to the body's reduced ability to fight off bacterial infections. Leukocyte Adhesion Deficiency is a rare condition that begins around the eruption of primary teeth. It is characterized by extreme acute inflammation, rapid bone loss, and profound defects in neutrophil and monocyte function. Patients often have frequent respiratory tract infections and sometimes ear infections. The absence of these immune cells in gingival tissues leads to severe periodontal destruction. In summary, necrotizing ulcerative periodontitis and refractory periodontitis are severe forms of gum disease with complex causes and challenging management. NUP can be classified into non-AIDS and AIDS-associated types, each with distinct features. Refractory periodontitis is defined by its resistance to standard treatments and must be distinguished from recurrent cases. Systemic diseases, especially those affecting neutrophil function, can manifest as severe periodontitis. Early recognition and tailored treatment are essential for improving patient outcomes. Thank you for joining us as we explored these important periodontal conditions.